Hi, I'm Rachel Arthur, and I want to introduce you to what has certainly become my best friend in clinical practice. So much so, I really can't imagine working without it. This is my patient pathology manager, and as the name suggests, it's going to help you manage your patient's pathology. The reality that we're faced with a lot of the time is results from different providers in different formats, coming in hard copy, electronically, all over the place. It becomes messy real fast, and so much so that there's a lot of noise. And it's really hard to cut through this noise and find the gems, find the real insight that you need to derive from this data on each patient. With the assistance of the patient pathology manager and certainly a little bit of data entry from you, you can find that we suddenly have order and clarity. We get cumulative results side by side. And I have a bit of a saying that cumulative data is king. It's incredibly important to understand how a patient is changing or not over time. And from this, you're going to get the really rich insights and understanding. So the patient pathology manager certainly stores and sorts your patient's data, but does it offer other solutions? Well, of course, I'm going to say a big fat yes. One of the things that we know is part of the process always in looking at a patient's labs is that we're making some sort of a comparison, and who we are comparing them to is a really big question. And is that a comparison that really is meaningful, that helps us to clarify when something is less than optimal or less than healthy and desirable? There are, of course, three different sources or types of comparisons. We have decision limits. There are not very many of those. They are regarded as healthy goals, and we generally have a scientific consensus about what they look like, for example, for cholesterol or CRP. We have a lot of reference ranges or comparisons that are actually derived in-house. So that means the pathology provider that your patient went and had their bloods performed by has collated the results of a small sample of their customers and mapped those results. And basically your patient their results are being compared to those. So it's really like comparing ourselves with our cohort, our neighbors and our community. The other source or type of reference range is, of course, external, and this is not at the hands of a private pathology company and their small cohort. This is a larger sample, usually derived nationally or internationally, and is often more of a consensus about what a healthy minimum or a healthy maximum might look like. But those last two are the majority of comparators that we're using. And of course, both of those two are based on the idea of a bell-shaped curve that individuals, in terms of their characteristics across a population, will demonstrate this sort of pattern, with the majority falling in the middle. And two standard deviations either side of that, we denote that this is the minimum and this is the acceptable maximum. It's an interesting statistical premise. It's highly contentious, of course, but one of the simple questions that we're left with is, well, where do we want to be? Where do we want our patients to be? Because unlike intelligence or joy or prosperity, more is not better. Do you want to be in the middle with everybody else? Let's say this is BMI. Clearly not. Do we want to be at the very bottom? Do we want to be at the very top? Do we in fact want to be outside of this bell-shaped curve and regarded as an outlier? Perhaps that is healthy. This is talked about by many researchers and pathologists, and particularly in this article by White and Kelly. And it really echoes our own experiences about this normal range. It's not so normal, and it's probably not that helpful as your only source of comparison. So let's take a quick look at a case to really make this more concrete in our minds. This is an individual in her 50s who was experiencing a lot of health issues. When we look at her liver enzymes, and particularly here we're looking at her GGT, which of course is routinely performed, we can see that her values, if we only use the comparison of the cutoff provided by the private pathology company of less than 50, generally sit within that expectation. There are two occasions when she's gone beyond what they deem to be expected or healthy. If we ask ourselves, well, what is that less than 50 really based on? Where does it come from? And what does it really reflect? And we have a look at GGT here. We can see that based on Australian data, Australian women with their GGT tend to sit anywhere between 9 and 56. And this less than 50 clearly has been an in-house determined reference range. So that pathology provider has, as I said, taken a sample of their clients and measured their GGT and said, look, we think anything under 50 is reasonable. If we go beyond that and we say, well, we're not really happy just looking at those people around us, that's not really aspirational and doesn't define wellness. Who does define wellness? Well, we can look at a national reference range, which is from the Royal College of Pathologists Australasia. These are included in the template. And you can see already that the upper limit of normal they provide is dramatically different for women there compared to the in-house maximum. So we say, oh, okay, well, you know, that's interesting that they have a different version of healthy. But is this really healthy? Their upper limit of normal is based on the suspicion of disease of the liver or gallbladder. So over 30 would be a tipping point for being suspicious of this. But is that healthy? Is the absence of a known liver or gallbladder disease really healthy? Certainly not when you're talking about GGT, which is a liver enzyme that reflects the metabolic and antioxidant milieu of the whole body, right? So when we go to international research where they've gone to great lengths to actually define what healthy looks like, we can see that a GGT in adult females should be under 19. So these figures are also included in your pathology template. You have been given not only the national consensus figures, which will often be different from your private pathology provider comparisons on the results, but you've also been given the gold here. This is the consensus in the research about what healthy really looks like. And these really approach something more akin to healthy goals, and therefore something more akin to what we described before as decision limits. So if we look at Oksana one more time and we look at her GGT, you will see that the template, again, is going to make this immediately obvious to you. While the pathology company didn't flag her GGT as consistently being really out of whack, and the RCPA said, look, it's a little bit out of whack for a female, we can be much clearer by looking at this goal of the independent research and this definition of what healthy looks like. And again, that is all in the template for you. So those results really narrow those goalposts and really help us to make meaningful comparisons for our patients in terms of their results. The other big area of meaningfulness with your patients' labs is finding their normal. So this really means that reference intervals, as we've described before, are very broad by nature often. And as White and Kelly remind us, your patient is unlikely to deviate very much within that reference interval, certainly for most of the routine screening tests. So we can see here patient A going up and down, but generally towards the upper end of the reference interval, and patient B doing the same at the bottom. The take home from this is that the patient pathology manager, by comparing your patient's results side by side cumulatively, gives you this opportunity to identify your patient's normal. The real value of this is any deviation from normal. Even if your patient does deviate in a way that's still within the reference interval, it is highly meaningful. And again, White and Kelly and many of others researchers reiterate this. This is probably your earliest alarm or alert system that there is an ensuing disease or disease process. So this is called intra-individual shift, and the template certainly helps you to spot that very, very quickly, very readily. Let's take a look. So here is a series of labs from a patient collected over 5 years, including just looking at those panels for hematology and iron studies. And on the surface, it looks all well and good because this patient is certainly sitting consistently above the minimum for hemoglobin, likewise for hematocrit. So these values here from the RCPA, and these are our more narrow reference ranges derived from the independent research. But on the surface, it all looks pretty good. We haven't seen anything fall below our general expectations. But when we take a closer look, what we actually notice is a drop. So this patient's normal is in the 130s for hemoglobin, and really it should be maintained there. When we see a shift in either direction, it alerts us to the fact that something new is at hand, something is underway. Similarly, you can see this reflected in this subtle shift down in terms of her ferritin. And likewise, over the same period of time, see certain things shift up. Together, this tells us very clearly what's at hand. I think the most exciting area for pathology and the most exciting thing that the patient pathology manager offers us is to look beyond single results and to look at the ratios and relationships between results of different related parameters. So what does that really mean? Well, it means that you are digging deeper into how these results really are meaningful in the whole body and what that meaning really looks like. So there are lots of relationships that are automatically calculated in the patient pathology provider. For example, what's called the Ritis ratio. That's looking at the relationship between the two liver enzymes AST and ALT. Traditionally used absolutely by mainstream medicine to help flag what the nature of the liver assault was. But now, far beyond that, actually helping us to pick up more subtle disease processes like androgen excess and adiposity, dysmetabolism, mitochondrial dysfunction, etc. Similarly, we can look at the relationship between albumin and globulin as indeed a more robust inflammatory marker than some of the traditional ones like CRP and ESR. Just looking at the mathematical relationship between the two will often help to highlight that the CRP is not telling the whole story. Also on the immune level, we have the neutrophil to lymphocyte ratio, for example. the more the neutrophil count dominates over the lymphocyte count, of course, there's always a natural dominance, but the greater this dominance, the more we come to appreciate that the immune response has become largely unregulated, and it's becoming more dangerous, more damaging to the host, because innate immunity is winning out over adaptive. So this is another really important ratio that the patient pathology manager automatically calculates for you, and of course defines what it should look like when things are going well. This is another illustration of that. This is a female patient who had ankylosing spondylitis. And you can see all the red and the yellow, which of course we've put in there, but just have a quick look at this CRP. This patient was profoundly unwell, but you wouldn't know it from looking at the CRP. But the patient pathology manager spells it out as clear as day. First and foremost, by calculating the albumin to globulin ratio for you and telling you that this is flagging marked inflammation. And secondly, while the neutrophil count sort of bobs up and down and certainly looks high normal to many of us, the neutrophil lymphocyte count is more, if you like, clear cut. It screams loudly that there is innate immunity excesses here and a lot of damage to the host along the way. So the calculated ratios within the patient pathology manager are many. These are the key ones. And as I said, it adds another layer, a profound layer to the full take home you are going to get from your patient's results. If cumulative data is king, then context is queen. And this might seem like a really simple thing compared to those sophisticated elements, but sometimes simple is beautiful. So having a look at this female patient in her 40s, we can see that her hemoglobin sits certainly comfortably within the RCPA and the more narrow, healthy expected range for a female. But we see with the most recent results a dip down. If we ask ourselves, well, hang on a second, that looks like an intra-individual shift. What happened there? The way that the patient pathology manager forces you into becoming a really diligent record keeper will answer this straight away. By documenting her reproductive stage, we now are clear that this is not an emerging anemia. This is in fact peak hemodilution, which is a natural physiological factor and stage in the second trimester of pregnancy. Unfortunately, not everybody made those connections and came to the same conclusion. So what we can see next, sure, the hemoglobin goes up. That doesn't look too worrying at all. But we can see in the third trimester, it's actually on the noteworthy high normal side for third trimester. Do we have a contextual framework or explanation? We sure do, because the patient pathology manager also asks you to document all supplements that are being used. And we can see that it was the administration of IV iron here in the third trimester after this result that has led to what we might regard as overtreatment and now really an iron excess. Similarly, with regard to documenting your supplements, this is patient's labs presented to me where the practitioner was scratching their head saying, I don't understand what this movement is all about in this thyroid panel. But when I popped in these results to the patient pathology manager and popped in the supplement context, it becomes blindingly clear what this is about. This is about an increasing iodine intake through supplementation and the very strong likelihood that this patient has hot nodules and is producing excessive thyroid hormone in response to that. But there's more, there's still more. So the patient pathology manager goes further than that. It also flags when results for your patient at any time point were not collected under optimal conditions. It comes with a training video. You can download a copy for every new patient, so there's no cap or limits to how many times you use this. We have a bit of a habit of updating and improving this template every year, and as a purchaser of this product, you will get those annual updates and improvements. And the joy at the end of it is ending up with really beautifully managed data on your patient like this that clearly brings to light what the processes are, what healthy and unhealthy processes are underway, and what's behind those things, whether it's dietary change, reproductive stage, the introduction or removal of supplements, and so on and so forth. And you can see those grey boxes around certain cells because of the less than optimal collection conditions in, for example, a fed state. It is my best friend in practice. I truly can't imagine practicing without it. And I have heard that echoed by other practitioners, which is very rewarding to hear. And we're always working on making it better. So I hope you enjoy using it and let us know how you go.